Hi class, this is the third part in this series on diseases of the digestive system. In this lecture, we will be looking at diseases of the liver. Before we start on the diseases of the liver, let's recap the normal functions of the liver. You have learned this in Year 1 Physiology, so let's see whether you still remember these functions. The liver synthesizes plasma proteins such as albumin, globulins, and clotting factors. The liver is also involved in excretion. Many substances are secreted in the bowel. The liver also plays a very important role in metabolism. In fat metabolism, fatty acids are brought to the liver. Also, triglycerides, cholesterol, and phospholipids are synthesized by the liver. In carbohydrate metabolism, the liver is responsible for storing and breaking down glycogen. The liver also makes new glucose, and that's called gluconeogenesis. In protein metabolism, the liver also plays a role in the breakdown of proteins. The liver is also the main organ for detoxification. Our nitrogenous waste, medicines, and chemicals are broken down by the liver. Let's also recap how the liver looks like. This is the shape of the liver. If you were to cut the liver and zoom in, you will see that the liver is made up of many hexagon-shaped lobules. Within a lobule, there is a vein in the center and many branches of blood vessels and bile ductules. Okay, so let's zoom in and take a closer look. The liver receives oxygen-rich blood from the hepatic artery and nutrient-rich blood from the portal vein. This portal vein carries blood from the intestines to the liver. The blood flows to the central vein here, which then feeds into the hepatic vein where blood is carried away from the liver and back into the heart. The liver cells or hepatocytes secrete bile which flows into the bile ductules. When you understand the normal liver function, it becomes easier to understand what happens when the liver is not working properly. Many patients with liver failure have edema, which means swelling. In this picture, you can see that the leg is swollen, and when someone presses the leg and then removes the finger, you can still see the depression on the leg. This is known as pitting edema. The liver is responsible for the synthesis of albumin, which is a plasma protein. So when the liver is not functioning properly, the synthesis of albumin is reduced. This reduces the oncotic pressure. What is oncotic pressure? Oncotic pressure is the osmotic pressure that is exerted by the plasma proteins to pull water back into the blood vessels. In the blood vessel, the blood pressure, which is also known as the hydrostatic pressure, pushes fluid out of the blood vessels into the tissues. At the same time, the oncotic pressure from the plasma proteins pulls fluid back into the blood vessels. So when oncotic pressure is reduced, water moves from the blood vessels into the tissues but is not reabsorbed back into the blood vessels. This accumulation of fluid in the tissues causes the edema. The liver is also responsible for producing clotting factors, which are plasma proteins involved in blood clotting. So if the liver function is impaired, the production of these clotting factors is reduced and the patient's blood will take a longer time to clot. Patients with liver disease may also have jaundice, which is the yellowing of the skin and the eyes. Why does liver disease result in jaundice? Normally, our old red blood cells are destroyed by macrophages and hemoglobin from the old red blood cells is released. Hemoglobin is then broken down to bilirubin, which is transported to the liver to be metabolized and excreted in bile. In hepatitis, bilirubin excretion by the liver is impaired, so it accumulates in the body. Since bilirubin has a yellow or brownish color, the tissues and body fluids are also stained yellow. The color of the urine is also affected by the excess bilirubin and it turns dark brown, which is described as tea-colored urine. Liver disorders can be detected by performing lab tests. The first 3 lab tests here are the most useful and therefore most commonly used. The liver contains many enzymes such as aspartate aminotransferase or AST and alanine aminotransferase, which is ALT. When liver cells are injured or die, AST and ALT are released into the bloodstream. Therefore, a high level of AST or ALT indicates liver damage. Gamma-glutamyl transferase, GGT, and alkaline phosphatase, ALP, are related to the bile ducts, so if their levels are high, it may indicate disorder of the bile ducts. Bilirubin is a bile pigment which is excreted by the liver. If the liver is unable to excrete bilirubin, then bilirubin levels in the blood will be high. Albumin is synthesized by the liver, so severe liver damage can cause low albumin levels. However, the albumin test is not very sensitive because albumin has a half-life for about 20 days, so it takes several days for albumin levels to increase or decrease. Also, there are many other causes of low albumin such as loss of albumin from the kidneys, inflammation, or malnutrition. Prothrombin time measures the time taken for blood to clot. If the liver is unable to synthesize clotting factors, it takes a longer time for blood to clot. Therefore, prothrombin time or PT increases. However, this test alone is also not very specific because vitamin K deficiency can also cause prolonged PT. The first liver disease that we'll be looking at is hepatitis, which means inflammation of the liver. Hepatitis can be caused by viruses, and there are 5 known hepatitis viruses: hepatitis A, B, C, D, and E. We'll be focusing on hepatitis A, B, and C since hepatitis D and E are not so common. Besides viruses, alcohol and drugs can also cause hepatitis. A person with hepatitis may present with symptoms such as upper abdominal pain, nausea and vomiting, anorexia, which means no appetite, fever, fatigue, and jaundice. Among hepatitis A, B, and C, hepatitis A is the most common and least serious form. Hepatitis A does not cause chronic liver disease. Most cases of hepatitis A are mild, and most people recover completely and become immune to further hepatitis A virus infections. However, hepatitis A can occasionally cause severe liver failure and even death. Hepatitis A is most commonly spread through consumption of contaminated water or food, so it is more prevalent in areas of the world with poor sanitation. A person who is infected with hepatitis A will excrete the virus in their feces, which may then contaminate the soil and water, leading to the spread of the disease. To diagnose hepatitis A, the patient's blood serum is tested for IgM antibody to hepatitis A virus. So HAV stands for hepatitis A virus. This IgM anti-HAV is the first antibody produced by the body when it is exposed to hepatitis A. So this test is used to detect early or recent infections. Since hepatitis A resolves by itself, there is no specific treatment for hepatitis A. To help with the recovery, the patient should get enough rest. Patients with hepatitis usually have nausea, which can make it difficult to eat. What they can do is try snacking throughout the day rather than eating full meals. To get enough calories, they can eat more high-calorie foods. For instance, drink fruit juice or drink milk rather than water. Patients with hepatitis should also avoid alcohol since alcohol can worsen the liver inflammation. The prognosis for hepatitis A is usually good and patients recover without any permanent liver damage. Hepatitis A can be prevented through vaccination. Of course, another way to prevent the spread of hepatitis A is to improve sanitation and food safety. Next, we look at hepatitis B. Interestingly, the hepatitis B virus does not directly kill the cell that it infects. Rather, when the cells are infected, the hepatocytes will express viral antigens on their cell surface, which are recognized by the immune system. So as a result, it is the host's own immune system that attacks and kills the infected hepatocytes. Hepatitis B can cause either acute or chronic disease. The likelihood that the infection becomes chronic actually depends on the age at which the person gets infected. Most infants or young children who get infected tend to develop chronic infections, whereas most adults who get infected will tend to recover from hepatitis B. People with chronic hepatitis B usually don't have any symptoms, but they can still infect others, so they are referred to as hepatitis B carriers. Unfortunately, about 20 to 30% of adults who are chronically infected with hepatitis B will develop liver cirrhosis and/or liver cancer. But fortunately, hepatitis B can be prevented through vaccination. Hepatitis B is spread through parenteral or mucosal exposure to infected blood or body fluids. The hepatitis B virus can survive outside the body for at least 7 days, so during this time, the virus can still cause infection if it enters the body of a person who is not protected by the vaccine. In highly endemic areas where hepatitis B is more prevalent, hepatitis B is most commonly spread from mother to child at birth or from child to child through exposure to infected blood. Hepatitis B is also spread by sexual transmission and through the reuse of needles and syringes among people who inject drugs. It can also be spread through needle stick injury in a healthcare setting. For the diagnosis of hepatitis B, it is actually based on the detection of the hepatitis B antigens and antibodies. Hepatitis B virus has 3 antigens, which are viral proteins, the surface antigen, which is shown in the diagram in purple, the core antigen, which is shown in red, and the E antigens, which are star-shaped. So when a person is exposed to the hepatitis B virus, the body's immune system produces antibodies to each type of antigen. So you have the anti-HBs, which binds to the hepatitis B surface antigen, anti-HBc, which binds to the core antigen, and anti-HBe, which binds to the E antigen. Laboratory diagnosis of hepatitis B infection focuses on the detection of the hepatitis B surface antigen, or HBsAg. This is a viral protein, so the presence of this protein means that there is virus present in the blood, and this indicates a current infection. Testing for antibodies against hepatitis B is also commonly done. The hepatitis B core antibody, or anti-HBc, indicates that the person has been infected with hepatitis B virus before. However, it doesn't specify whether the person is still infected, has already cleared the virus, or is already immune to reinfection. Hepatitis B surface antibody indicates that a person has already become immune to hepatitis B. This is a more detailed explanation of the diagnosis of hepatitis B. Let's look at the situation of an acute hepatitis B virus infection followed by recovery. The hepatitis B surface antigen is a viral protein and indicates that the person is infected with hepatitis B virus. When a person is infected, HBsAg levels rise, and when the person recovers, HBsAg disappears. When a person is exposed to a virus, the body produces antibodies against the viral antigens. 2 types of antibodies are produced, IgM and IgG. IgM is the first to appear in response to the initial exposure to an antigen. So we see here that IgM antibodies against the core antigen are produced. As time passes, IgM levels drop and IgG antibodies will be produced instead. The total anti-HBc includes both IgM and IgG antibodies to the hepatitis B core antigen. So initially, the rise is contributed by IgM antibodies, but later on, it reflects IgG antibody levels. These antibodies against the core antigen do not confer immunity. It is the antibody to the hepatitis B surface antigen, or anti-HBs, that actually confers immunity. After the person recovers from hepatitis B, the person develops anti-HBs and therefore becomes immune to subsequent hepatitis B infections. Now look at the table. What lab results would you expect in a case of a person with acute infection, a person who is immune to Hep B due to a past infection, and a person who is immune due to vaccination. Do you think they will have positive or negative results for each of the antigens and antibodies? Press pause if you want to come out with your own answer first, then press play when you're ready to come out to check your answer. For a person with acute infection, refer to this part of the graph highlighted in yellow. HBsAg is present, total anti-HBC and IgM anti-HBC are present. The person has not yet developed immunity to hepatitis B, so anti-HBs is negative. For a person who is immune due to a past infection, refer to this part of the graph highlighted in blue. Only total anti-HBC and anti-HBs antibodies will be present. What about someone who is immune because he received a vaccination in the past? The answer is not found in this graph, but I'll give you a clue. The hepatitis B vaccine contains the hepatitis B surface antigen only. I hope you guessed the answer correctly. The person would have developed antibodies against the hepatitis B surface antigen, so only anti-HBs will be present. Now let's look at the situation of chronic hepatitis B virus infection. When a person is infected, HBsAg levels rise. Since this is a chronic HBV infection, the person continues to be infected and the HBsAg levels remain high. As mentioned earlier, IgM is the first type of antibody to appear in response to the infection, so IgM antibodies against the core antigen are produced. As time passes, IgM levels drop and IgG antibodies will be produced instead. Since total anti-HBC includes both IgM and IgG antibodies to the hepatitis B core antigen, the initial rise is contributed by IgM antibodies, but later on it consists of IgG. Since a person with chronic infection is not immune to hepatitis B, we don't see the production of anti-HBs antibodies. So now, what lab results will you expect in the case of a person with chronic infection? Press pause if you want to come up with your own answer first, then press play when you're ready to check your answer. For a person with chronic infection, they have already been living with the infection for quite some time, so refer to this part of the graph highlighted in yellow. HBsAg and total anti-HBC are present. At the stage of chronic infection, the person has already been infected for some time, so the IgM antibodies against the hepatitis B core antigen have already disappeared. And since the person is not immune to hepatitis B infection, there are no anti-HBs antibodies produced. There is no specific treatment for acute hepatitis B. Treatment is aimed at maintaining comfort and adequate nutritional balance, including replacement of fluids lost from vomiting and diarrhea. Chronic hepatitis B infection can be treated with medicines, including oral antiviral agents. Treatment with these antiviral agents can slow the progression of liver cirrhosis, reduce the incidence of liver cancer, and improve long-term survival. However, in most people, the treatment does not cure hepatitis B infection, but only suppresses the replication of the virus. Therefore, patients with chronic hepatitis B would have to take the medications for life. Now let's look at hepatitis C. Hepatitis C virus causes both acute and chronic infection, but the majority of patients, around 60 to 85%, will get chronic infection. Those who develop chronic hepatitis C are at a greater risk of developing liver cirrhosis and liver cancer later on. There are multiple strains of the HCV virus. The hepatitis C virus is most commonly transmitted through blood, for example, through reuse of syringes or needles. Hepatitis C virus can also be transmitted sexually or from an infected mother to her baby. However, these modes of transmission are less common. Acute HCV infection is usually asymptomatic. Therefore, few people are diagnosed during the acute phase. Even in those people who develop chronic HCV infection, the infection is usually asymptomatic for many years until the person develops serious liver damage. Therefore, many people are diagnosed with HCV only after they have developed significant liver damage. HCV is diagnosed in two steps. Firstly, a blood serum test for anti-HCV antibodies identifies people who have been infected with the virus. However, this test does not indicate whether the infection is still present or has already been cleared. So, if the test is positive for anti-HCV antibodies, then a test for HCV RNA is needed to confirm that the person is still infected with HCV. The treatment for HCV has changed a lot in the past few years. Newer medications which are safer and more effective have been developed, and these medications can actually cure most patients with hepatitis C. However, there is currently no vaccine for hepatitis C. Okay, for viral hepatitis, we have looked at hepatitis A, B, and C. Try to summarize the differences by filling in the blanks in this table. The first row, onset, has already been filled in for you.
Earlier, we have seen that chronic hepatitis can lead to cirrhosis. But what is cirrhosis? Cirrhosis refers to the late stage of fibrosis or scarring of the liver. Cirrhosis is usually caused by chronic alcohol abuse, chronic viral hepatitis like Hep B and Hep C, and non-alcoholic fatty liver disease. This picture shows a healthy liver on the left. On the right is a liver with cirrhosis. In cirrhosis, normal liver tissue is replaced by scar tissue, which is fibrous tissue. The liver is unable to perform its vital functions. To sum up, in this part of the lecture, we have covered the general signs and symptoms of liver disease, such as edema, coagulation abnormalities, and jaundice. We have also looked at the three main types of viral hepatitis, which are Hep A, B, and C. While Hep A often resolves by itself, Hep B and especially Hep C can become chronic infections. However, now that Hep C treatments are available, cure is possible for Hep C patients. These medications are very expensive, but there are initiatives from the government and charitable foundations to improve the access to these medications.